Good evening, everyone. Hello, good evening, and hello to all the senior faculty, and good evening to all the residents. So today's topic is something that we all find a little scary, to be honest, as residents. Therapy. So basics of CBT is the topic, and let me just share the screen so I can. So our speaker for today is Dr. Shobha Khatte ma'am. Ma'am has a doctorate in clinical psychology from the University of Mumbai in 1982, much before I think most of us have been born. She has an advanced behavioral therapy and she's done her advanced behavioral therapy and biofeedback course in NIMHANS, Bangalore. And she set up the first behavioral therapy unit at KEM Hospital, Bombay since then. Ma'am has done her training in rational emotive therapy from Professor Kishore Padke sir, and she has been the training supervisor of Institute of Rational Living, New York, and has conducted multiple training courses in REBT for social workers, medical graduates, industrial executives, and workers and lay people. Ma'am has been the clinical psychologist in KEM Hospital since Jan 72, and then she opted for voluntary retirement in 1994. Ma'am has since then had her private practice at Dadar and Thane till 1999, and Thane ma'am is still practicing. She's the founder, member, trustee, and clinical supervisor of IPH, which we all have heard. And she has started in 1990, and she's still actively involved in planning executive IPH projects and supervising all the clinical staff till date. Welcome. As our chairperson, we have Dr. Anuradha Sovani ma'am. Ma'am is a psychologist and psychotherapist. Ma'am was a former professor and head, Department of Psychology, and former dean, Faculty of Humanities at SNDT Women's University. She is the trustee and consultant at IPH Thane. Ma'am is also a part of the National Core Committee member and Ethics Committee chairperson for Association of Adolescent and Child Care India. She's also on the Ethics Committee of Jaslok Hospital. Ma'am is the co-founder of Noah Click, which is an innovative online aggregator platform which provides consulting with client organizations. Welcome.
Thank you so much.
I think before you begin, I would just say that I must say I was fortunate that I joined the Department of Psychiatry in 1993, and till 1994, when Khatte madam decided to take retirement, I was in the department and I could learn from her. So I consider myself lucky. And after that also, whenever we've been in touch or if we met at any BPS or any other, it is always an inspiration, because at this age, she has adapted to the technology and she's going strong. And today also she's planned the session very well with her student going to do the role play. And I think it is something that is very, very inspiring. And second thing that I want to say is about the topic for all the residents, that of course CBT is a theory question, and CBT can be asked in your cases also, because whenever relevant cases are there and when more interventions are asked, you answer CBT. And then when more is asked about it, usually there are issues. So it's important. But third most important part for all of us is to also learn CBT for ourselves. Because I think if as mental health professionals, we don't know how our thinking affects our feeling and our actions and behavior, then it's of no use. So I think for us also, it's a big skill to learn so that we are mindful of our thoughts and we can change them and they remain in our control. Because nowadays we hear a lot of cases of so many residents, and So I think for residents also, it is important to learn for themselves. And thank you, Anuradha, for being here at just one phone call. Anuradha from Mumbai University and then SNDT University, and her students and her coming to KEM for internship. So we've been in touch till much later. And she has always been a friend, and also she has come and been a speaker for many of KEM programs as well. So welcome both of you. Thank you for being there, and over to you. Anuradha, if
Thank
you
you
want
for
to
having
start
us.
this session.
No, I think I won't have anything to add when Tatya ma'am is teaching you CBT. I'll just take a minute to say that I really couldn't say no, and I'm saying this again, for anything, however crazy busy life is right now. With Shilpa asking and with ma'am training, I don't think I would have missed this for anything. My journey in CBT began with Thatte ma'am actually. I must share that she's my PhD supervisor. Today she's my friend, philosopher and guide. And we still share so many things almost every second day pertaining to therapy as well as other stuff. There's always something to learn. Particularly, I want you to look out for the thinking behind the unraveling of the case. Because you'll find a lot of excerpts of therapy in books. But I think the understanding of it has to run deep. And that is something I have seen with ma'am, who, like I said, we studied REBT together. As an academician, as a teacher of the university, I will only say that there is no one CBT. There are multiple cognitive therapies, and the more you get deep down into them, the more there is to learn. So the only role I'm going to take today through this 1.5 hours, because all of you are studious and very intelligent, very intense exam going people, I will just keep dropping certain points in the chat box, readings, or different people who have contributed to REBT, CBT, all the other cognitive therapies, and there are many. So don't be overwhelmed. There may be 7, 8, 9 names that may come up. You definitely are not going to need all of that for exams. But it's good to know, like Dr. Shilpa said, it's good to know how many layers there can be to CBT. So I will not interrupt, ma'am. I will just put that in the chat along with something in brackets to show you largely where that particular form of cognitive therapy gets employed, whether it's for bipolar or for self-harm or for depression. So if you have questions, put them in chat. So I will reply. And we won't interrupt the flow because we just have an hour and a half. And if we had a year and a half also, it wouldn't be enough. All the best. I hope you enjoyed the session. I'm sure you will. And over to you, Thattiman.
Yes, ma'am, you can start.
Yeah, shall we start? Thank you, Anuradha. Actually, Anuradha, as we call in music dynasty, we are Guru Bhaginis because we started learning cognitive behavior therapy together. So, from that point of view, we are Guru Bhaginis of Professor Parke. Good evening, everyone. Let's start with today's topic, cognitive behavior therapy.
It's a little soft for me, ma'am. Let's just check that everyone can hear you.
Hello.
It's a little soft, so if you
Ma'am,
can
if you could be a little louder, and also if you could do the slideshow so that the screen, the slide becomes bigger.
Shall we?
Nice sound खूप low hai, so if you can be closer to the mic, it will be good.
So, good evening,
We can hear you, so it's not bad.
Today we have the audience. In audience, we have almost all the people who are practicing psychiatry. So I can understand when you you have a client in front of you, patient, and you start talking, your first focus is on what are the symptoms and look at the symptom in terms of DSM-5. Think about diagnosis in your mind and think about what would be the molecules I will be prescribing to this person. So where does cognitive behavior therapy come in that? That is more important because you are prescribing the drugs, but at the same time, if you focus on the thinking styles of the patient, it will definitely help you in treating patient in a much better manner. So I'm not going to teach you cognitive behavior therapy or say much how you can use CBT principles while talking to the client, while coming to your inferences, and how to handle and have dialogue with the client and the relatives. So that will be a more focus of today's topic. So let's go to next slide.
Uh, can can you maybe remove your headphones? The voice will be a little clearer, is what we feel.
Also, ma'am, can you please do the slideshow?
Let's look at it as what is the how was the development of CBT which has taken place. That basis is more or like RT, that is the rational therapy, which was by Ellis in 1955, which became rational emotive therapy in 1961, and then it was taken as REBT in 1993, and also Aaron Beck's cognitive therapy, which came in 1976 in Europe. After Ellis's revolutionary presented in 1955, that was in American Psychological Association's annual meeting in 1955 in New York. And Albert Ellis presented his paper on his theory of RT, rational therapy, which was on the background of the then prevalent Freud psychoanalysis and conditioning theory. So it was more like a bombshell for each and everyone in that audience. But many other stalwarts like Glaser, Mischenbaum, Beck, Bandura, they came forward with their modified version of their therapies. And all these are collectively called as cognitive behavior therapies. So CBT also uses the contributions of earlier therapy theories, right from Freud's defense mechanism, Jung's concept of real self-realization, Adlerian concept of dynamic change in the client, Rogerian principles of empathy, listening, and reflecting, then behavioral principles through homework assignments, and feeling and experiential part of Gestalt therapy. Sometimes in CBT also we use religious concepts and principles from scriptures. If client is more comfortable with that and averse to the psychological jargon. Now let's find out what we mean by CBT. Importance of cognition is not something new. It's an ancient knowledge. Right from the time of Epictetus, people are disturbed not by things, but the view they take of them. Here also Epictetus focuses on cognition or thinking. And also in Vedas, man is made by his beliefs. As he believes, so is he. But all these quotes remain on the walls unless they are converted into a framework for solving problems of daily living. And that framework we are going to talk about today. That framework is not AC, but ABC. Now here what we mean by AC, A is something happens around us. Or something even if doesn't happen, but in our mind we remember something. And C is the consequence of that, the reaction, which may be emotional, which may be behavioral, which may be physiological. So all kinds of consequences are there. And most of the time we think about, I became very angry today because my son said this to me. And in AC to ABC, we turn to not my son said something and I became angry, but my son said something and I became angry. We replace because to and, because there is something in between which is known as B. So in ABC, something happens around. There is a reaction, which may be behavioral reaction, emotional reaction, but that is not because of what happened at A, but what I started thinking about it. So this is the basic principle which one has to understand to go to the to go further to understand what is. So the first step for each of us is to follow the principle of not AC but ABC. And therapist cannot become a therapist unless he or she understands, imbibes it, and follows it. For example, if I'm talking to a parent and the mother is complaining about the son, I have given him so much, there are all the facilities at home, but still he doesn't study at all. I'm so upset because when I see him not holding the book in his hand, I become very angry. Now, suppose I, as a therapist, also hold the similar belief that yes, son has to study if the mother is insisting. How am I going to help this client? So, as a therapist, unless or otherwise I follow these principles in my thinking and behavior, I will not be able to understand and explain to the client what is her distress about. And that's why it is very important for each of us to first understand the principle, try to follow it in your own life, and then only you will be able to preach the client. I'm using the word preach because the hallmark of CBT that it is educative. We educate the person to think in a different style than what he has been for all these years. So as if it is for the client also, it is as if he has been thinking all this while that the sun is rising in the east. And we are teaching him sun is going to rise in the west. So it is as diametrically opposite to his usual thinking. We'll find out always people around us always thinking in this manner. The thinking manner is AC. That means something happens, I become angry. And unless and otherwise that A changes, I will not be able to bring my emotions under control. So here we are trying to teach the client that that an event is not going to change. But you have to understand your emotion is mainly because what you think about that event. And that's why the hallmark of CBT is it is structured therapy. It is goal directed. It is collaborative, which is very important. Collaborative because the client has to equally work with the therapist. Whatever exercises are given to the client, whatever thinking has been, discussion has been going on during the session, the client has to imbibe it. Client has to show his full enthusiasm to work for himself. So it's not something that I have to talk to the client and the client goes and he becomes better. So it's a collaborative thing he has to. Homework are the techniques and worksheets which are paired with the session games. Now, homework is another contribution as compared to other therapies earlier. Because whatever has been taught in the session, suppose the session is 45 minutes and I'm going to meet the client after 10 days. Whatever has been said and discussed in those 45 minutes has to remain with the client and the client has to think about it. So by the time he comes for his next session, he has tried to imbibe some of the principles which he has learned. And in order to underline that, the homework is given to the client. And that's why the homework is not something which is given at random, but something which is done in this particular session. The homework should be paired with that. It should pair with the session games. Now, when you are talking about the qualities of the therapist, these are the basic qualities in any counselor, any therapist: empathy, genuineness, and positive regard. So I'm not going to go into much detail of all these things because you're all aware of that. But I'm going to focus mainly on empathy, which is extremely important. Because as a clinician, when you focus on the client, your thoughts are always directed in the direction of diagnosis. And in that, obviously, you lose empathy, you lose the connection with the client. You don't understand the body language of the client, what the client is meaning, what is he trying to relate to you. That is something many a times lost because of your focus is somewhere else. So it's important that even if we are focusing for diagnosing and prescribing, it's important that you have to understand what the client may be going through, what he must be disturbed about, what are the things in his life which are making him come to you. So that empathy is something which is extremely important, that what the client is feeling in his mind about what is happening. And that empathy is something that you don't have to feel and keep it to yourself. It is to be expressed to the client. The client should understand that the person who is sitting in front of me is understanding what is going on in my mind, what I'm disturbed about, what is my disturbance about. So that empathy is something which is extremely important. And I think many a times we see that people who are extremely busy in their profession, they lose track of empathy. Because their focus on is many a times on the next patient who is waiting outside. So for that particular patient, it's very important that the dialogue between you and the patient should be such that your empathy should be, the person is understanding that you are empathizing with his problem. Apart from that, the CBT therapist needs to be very active. All the earlier therapies were mostly dependent upon the fact that the client is sharing something in his or her life. And the therapist is nodding, understanding, and commenting in between. But in all the CBTs, the therapist has to be very active and directive. The therapist should have in mind, in this particular session, what do I want to achieve? At the end of the session, the therapist should be able to summarize the gains of the particular session. What is the take-home message with today's session? That should be again repeated to the client. And that's why we call it directive. Because it is directive, the therapist has to be also assertive. The take-home message which we want to give to the client has to be driven in such a way the client understands that what we are trying to teach him. We are going to do some snippets of some session in which we will also understand how the therapist has to be assertive in that. He also has to be exploring, get feedback during the session, how much the client has understood. If necessary, you may have to give some other examples and continue with the same principle which you are trying to teach in this particular session. And that's why getting feedback during the session is also equally important. Asking the client questions about that. Allowing the client also to question you for something which he has not understood. So how does the therapy go? Identifying the themas that work. Aaron Beck uses the word thema and Ellis uses the word belief system. They are one and the same thing. So for understanding what is the thinking style of the person, obviously the client doesn't come to you with his belief system. He comes to you with his complaint. That means he tells you about the seeds. I have difficulty sleeping. I'm very depressed nowadays. I find it difficult to get up in the morning and go to work. So what he talks to you is about the C, consequences, and also about the age, what has been happening in his life, which is upsetting for him. So B is something we don't get on the platter. We have to go through what the client is saying and understand what could be the thinking behind. And that's why the information that the client is giving you, all the information may or may not be relevant. There is some relevant information, there is some ancillary information. So as a therapist, you have to understand what is important for me from that information, which is going to help me understand client's thinking. Many a times clients come to us with a different idea about therapy. Because they have read about Freud, they have read about other therapists, and they feel they have to come and tell everything that is coming to their mind or everything that has happened in their life. At that time also, if our face shows that I'm bored by what you are saying, the client will immediately stop or he will go on and on without looking at your face also. So it's important for a therapist to find out where to stop the client without interfering his emotional flow. Many a time the client may blabber so many things in his life. Sometimes it is possible that the client has come only to get it out of his chest, just to talk to you, just catharsis effect. But there also we have to understand that information is important for us to find out his thinking style. Sometimes the client may come with the activating event. Like last week, my boss told me this in the office. And I was so upset that after that, I don't feel like going to work also. And I feel like resigning. So there is a certain activating event when it has started. And it may have also some other preceding information which has led to that. Sometimes the client may come without any activating event. There is absence of activating event. The client may say, I don't know what is, nothing has happened. But I'm feeling low for the last 6 months. I'm not interested in doing anything. I'm not interested in things which were very interesting for me earlier. So here, as a therapist, it is important for us to find out what must be the activating event, which might not happen, but which is in the client's mind. So all these things, the section material that we have, that gives us lot of cues about what might have been going on in his mind. Now, when we talked about ABC earlier, what are the B's? B's are the perceptions and evaluations of situations, people, conditions in the world. If the client tells me, my sister-in-law criticized me, and I was very, very upset since that day. I don't feel like even looking at her face anymore. Now, actually, what is the fact? The fact may be some sentences used by the sister-in-law. So that is fact. The next stage is the P, that is perception of the person. That means the inferences the person has drawn from that what that person said. Those inferences are there. And after that, because of the inferences, there may be some evaluations where the person may evaluate self or the person who said those words as, I must be really awful because she said so. Or she is certainly awful and nasty person. So there are evaluations later on. Therapist has to catch up which is P and which is E, and assess the client's level of disturbance to decide how far one can go in challenging one or both in the first session. Here we find out the little difference between CBT approach and REBT approach. How does that happen? As I said, P is client's interpretation. When the client is talking to us about the activating event, actually it is not the fact of the event, it is A plus part of B. When she said earlier example, when the person said, my sister-in-law criticized me. So actually the A is sister-in-law said something. And patient is telling us as she criticized me. So it is A plus part of B. Mita feels that no one wants to make friends with her. She had gone for a party and she felt that all the other people were talking to each other and very happy, but they were ignoring me. Now, what has caused the distress? That she is feeling lonely and unwanted because of her inferences from what has happened in the party. So when we are working only on the P, that is perception of the person or the inference of that person about the event, we are using Beckian approach. What do we mean by Beckian approach? The same example, when Mita said, yeah, I felt very lonely and unwanted. Beckian approach would say, the things are not as bad as you feel about it. So I'm sure there may be some people who might have talked to you, might not have been as much as you expected from them. But there could be various reasons for which they have not talked to you. So we try to tell the client, the situation is not as bad as you think about it. And the identity approach is not only working on perception, but also evaluation. What is the evaluation here? Because Mita feels nobody wants me. I'm worthless. I'm sure I will never get friends in my life. And REBT tries to help the person not to evaluate oneself, one's worth on the basis of what people are doing. And because of this difference, we say that REBT is an elegant therapy. What do we mean by elegant? Because the belief is a thinking style which is applicable in many other situations. So if you are using REBT approach here, we teach Mita to face such situations in a way by which she doesn't make herself miserable and doesn't attach her worth to that situation. Because her feeling that people are ignoring me may not be only restricted to that event. It may be generalized to many other events also. So REBT is elegant because we don't only help the client for the problem which the client has brought, but also the other problems in his life which may be related to the belief. So that's how we differentiate between how to find out the marks in that. Here again, identifying the client's emotions is also important. Many a time, client may not talk about emotions. They may talk only about behavior. So you must have some hunch about when he talks in the behavioral terms. Usually, whenever there is avoidant behavior, there is anxiety. The boy says, I don't want to appear for my JEE this year. I'm going to appear next year. So what stopped him from doing that, though he was studying for 2 years, is anxiety, fear of failure. He may be showing some other reasons for that. But we have to understand there has to be some underlying anxiety when the person is trying to avoid something. As you always see in your cases of OBS, that the person doesn't want to go by the elevator and he avoids using the lift. Why? Because there is anxiety about something that is what will happen. Will it stop in between? Will it cough? Will I be inside and I get a panic attack? So there may be number of such anxieties in the person's mind. Similarly, if there is aggressive, abusive behavior, the prevalent emotion will be always anger. Inactivity, lack of interest, the emotion will be depression. The person may not say, I feel depressed. The person will say, I don't feel like doing anything. Yes, I used to I always like to listen to music. But now whenever I switch the music on, I feel like switching off it. Similarly, if there is a behavior of self-injury, there has to be guilt and shame as the main emotion. So if we keep those hunches in mind, we will be able to go to that emotion, go to that core emotion to help the person in that manner. Then there is another group which comes with psychosomatic problems. There are physical difficulties, some problem with others. And they talk about various physical symptoms, but refuse to have any stress. So now we are going to see one case here. I'm not going to present to you a session. I'm only going to show you snippets of, in some cases, what we try to get out of that, how we communicate there, and how we try to give the necessary information to the client, which is based on CBT principles. So, Geeta, are you there?
Yes, madam.
Hello, Geeta. Yeah.
Hello, madam.
So, Geeta and me are, thank you, Geeta, for coming here. Geeta is a psychologist who is working with IPH. And we are presenting a part of a case. Okay. She has come to me with multiple somatic symptoms. She has two plastic bags full of different investigations and their reports and everything. And she has come with the symptom of severe headache and backache for the last few months. So, Geeta, that's what your physician told you to come and meet me.
Yeah, madam. My physician told me to meet you 8 days back only. I could not come for some reason, but I have got back all the reports. Everything is normal.
Keep them up. Keep
Yeah,
them.
yeah.
All the reports. Your physician has talked to me and told me that the
Yeah.
reports are fine. Yeah.
So, actually, ma'am, I don't have any psychological issues. It is just that my back is paining very badly. My waist is also at times not allowing me to work at a stretch. And my hands, my shoulders also pain a lot at times. So that is the only difficulty. But the
Does it
physician
limit
told
any
me to meet you.
activities?
Yes,
Does
ma'am.
it limit any activities?
Few of the times I'm able to do it, but few of the times I'm actually stuck and I'm not able to do it, ma'am.
Yeah, yeah. But it troubles you all the time.
Yeah, it troubles me. It does trouble me.
Fine.
Actually, ma'am, I was a teacher in the school, but because of my mother-in-law's health, I had to take a break.
Yeah.
And my husband is always touring, and my son is actually at Manipur doing his engineering. So that is the background. So right now, only two of us are there at home.
So he's staying in hostel there now.
Yeah, he stays at the hostel at Manipur doing engineering. Yeah. So actually, 2, 3 days back, madam, he had called up and he said that he's appearing for his first semester engineering semester exam. Obviously, he was quite tensed when he was talking to me. And I actually started worrying because all this while for his 10th board exam, for his 12th board exam, he was just with me and I was able to with him, I was able to be there making coffee and talking to him all the while. My husband was never there because he has a sales job, so he's always touring. So therefore, bonding between me and my son is very good. And therefore, when he is now tensed for the exam and I am not there, I was just thinking how it can happen that my son's exam is there and I'm just not next to him. So,
When you came, you said, I don't have any problem. I don't have any stress. But let's see why all these pains are there. Okay.
yeah,
Let's start with something else. Which dish do you like to eat? Tell me.
pav bhaji.
Pav bhaji. Okay.
Yeah.
So imagine there is a plate of pav bhaji in front of you. Okay. Hot pav bhaji with onion on that,
Yeah.
steaming. And when you look at it, you are happy. Close your eyes and imagine that this plate is in front of you.
Okay. I
What
actually
happens?
started getting smell also, ma'am, after closing the eyes.
Your mouth is watering.
Yeah.
Isn't it? Why? There is no pav bhaji in front of you. So
No.
even thinking about that, you have a bodily reaction, isn't it?
Yes.
That's what happens when we have many physical symptoms. There may be something on our mind which may be affecting our thinking. And that's all. So you just now, I saw your paper. You were asked by your physician to come and meet me some
Yeah.
10 days back. But
Yeah.
you took appointment only 3 days ago.
Yeah.
So can you tell me 3 days ago what happened? You felt like taking appointment and coming to me. Did anything happen that evening?
Actually, my son's call only came on that particular day. And because he was tensed, I got tensed over here. And the only feeling that I am not with him or he's not near me was making me little in awkward position, and I was feeling little restless about it, ma'am.
And did it remain only till you talked to him? When you put the phone back, what was going on in
Actually,
your mind?
no, ma'am. Actually, when I go to clean the room every day, go for dusting, go to his room, then that is making me still more difficult because all his memories come back to me. When I'm eating anything on my dining table, I feel very criminal that he's not
Next
eating and
morning,
I am eating his all favorite dishes and all. So those are all the things that I definitely miss.
and next morning when you were feeling your husband's tiffin, that time
I
what were
that
the
is
thoughts?
that is the most I mean I get very sensitive at that time because I was making tiffins for my son and I was making all the favorite dishes. I used to plan every week what he likes and all. And nowadays I'm not able to give anything to him. So that also that
Even if you
missing
are not,
part is there.
yeah. So even if you are not talking to him or doing anything, it is on your mind.
It is all the while playing in my mind. Yeah.
So that's how many a times our thoughts, our anxieties, they reflect in our bodily responses. I think we'll stop here because you don't want to do any full session. But now you can understand what has happened in this session. What messages I tried to give her. First thing I tried to tell her how the body and mind are related, how your thinking affects your body. So if I would have started with this immediately, no, it is all because of your thoughts. It's all because you keep on thinking about certain things. Stop thinking. She won't have accepted, certainly. So we have to see to it that we drive our message to the person in such a way that it becomes convincing for her. When she started telling the history about her family and everything, I have already started creating some hypothesis in my mind. What may be the reason for her distress? When she said the son who was with her all these years, and now he has gone to first him. The likely hypothesis in my mind I started to find it. And that's why I asked her about what had gone, what was in the conversation between she and her son. So now we know that her anxiety is related to my son is away from me and I can't handle that situation. I find it very disturbing. And that is causing trouble. So now we know when we start talking to the client also, we want to give some information to the client. But that information should go in the flow of conversation, not in terms of, "Okay, now I'm going to teach you how the body and mind are related." So whatever information we are going to give her has to be in the flow of the conversation. So she picks up the thread and she herself now started thinking, do I really keep on thinking about that all the time? and is that likely to affect you? If the client is narrating the victim role, many a times we have clients who keep on telling about how things have been bad, how their office situation is bad, how their bosses are troubling them, how other people in the office go to the boss and do chamchagiri against him, and that's why he's very much distressed. So people like to talk about it all the time. It's important for the therapist to decide how to how not to make them continue about it. Because once we get the basic thinking behind it, I can't stand people behaving like needing that like this manner. That should be the basic thinking. So all her 10 situations which we narrate may have a common belief in that. So it's important for us because if we keep on listening to that and encourage him talking about it, we will be reinforcing his attention seeking. So there it is important that we have to summarize and say, you can understand. For you, the office situation has become very difficult to handle because you feel that people around are not as cooperative as you want them to be. Now, I particularly chosen the person in the manner that I have not labeled those people in any way. I have you chosen the words that you want them to behave in a particular way, and they are not behaving like that. So through that, I am also giving a message of AB to ABC. That it's not people behavior that is making you upset, but it's your inference. They are purposely troubling you. The boss is purposely giving you extra work that is making you upset. So that AC, ABC, unless we have in our mind all the time, we will not be able to bring it in the session while talking to the client. And we should not miss even a single opportunity to teach the client that how his thinking is making him upset. Similarly, there are many situations which we need to be very assertive with the client. Let's see another role play. Gita, shall we start with this?
Yes.
So this is the background of this session is this. Because we are going to show you only 5 to 10 minutes out of that 5 minutes of that session. He's the client who has been coming to me for his alcoholism. He had gone to rehab. He has come out of rehab. After that, he has been sober for quite some time. It is almost 8 months that he is sober and has not touched drinking. And he's regularly following the therapy at least once in 15 days or now later once in a month. But today he called me and took a special appointment out of turn because he wanted to come and talk to me about his relapse. That he had a drink that evening with one of his office colleagues and how he was tempted to go and drink with his colleague. He has already narrated to me everything about what has happened and how did he got into the trap of going with the colleagues to their regular bar and had a drink. But after that drink, he immediately got up out of that bar and came out. And then he started feeling very guilty for what has happened. And he wanted to come and share that with me, which he has already narrated. Now, the next part of the conversation is like, so Nikhil, you said all these things had happened. And this happened last evening.
Yeah, madam.
Did you share it with your wife?
Madam, I have no guts to share with her. I just can't even show my face to her. I'm feeling myself so guilty about it. She has made so much of efforts, madam, for me, for my rehabilitation. And these 8 months that I was able to remain sober is only because Nirmala helped me to do that. Oh, I have no guts to tell me, ma'am. No guts.
What do you think? What will be her reaction?
Madam, To be very, very frank, I will tell you that she will just leave me and go away now, because that was the last chance that she told me that she will give me last time. So now, how many last chances even I can give her? She will actually, ma'am, leave me and go. I don't want that to happen in my life.
But in your mind, what do you feel if you want to hide it from her all the time?
Madam, if you ask me, I really do not want to hide anything with her, because last 8 months to 1 year, everything that I have done, everywhere she was with me. And I really feel guilty that she's not knowing this. I want to share, but I have no guts, ma'am.
What is your fear that now you feel that
Fear
she is
is,
comfortable, she doesn't suspect you, she doesn't come and sniff at your mouth?
now she doesn't do
Fear,
that, ma'am.
yeah.
But now
That
it will be,
all has stopped because
yeah,
now there is some trust between you and her.
yeah,
And you are afraid that trust will be broken.
that, yeah.
But because she has been partner in this all the while, isn't it important that she should know that this has happened and you are feeling guilty about it and you promise that it won't happen again?
Madam, I completely agree to what you say, but I give you her number. I will give you her number and you only speak to her and you only tell her, madam. She will
No,
believe you. She will not believe me.
I'm not going to tell her.
Madam, please, you do
Important that
that.
you narrate it to her. Okay, we will find out a midway. I will give you appointment for both of you.
Okay.
Okay, so I will be there with you.
Means you will tell her, no? You will tell her.
So, and you tell her, but I will be sitting there as
Oh,
you narrated to me. You can narrate the same thing, what happened in the office. How did your friend Deshpande ask you to accompany you with you to the station? And because the bar was on the way, he dragged you inside. Did he drag or you went on your own?
madam, he dragged and then I went.
So this is something which needs to be narrated to her, isn't it? So do you think after telling her all these things, her impression about you will become negative or she may feel
Probably, madam, if I
shame?
probably transparently, if I try to share
Yeah.
with her honestly, she may, madam, I'm not sure, but she may give me a chance. She's good. She's a good wife of me.
Yeah. So even if she feels that he had, he was tempted to go and drink, she will also feel he is very transparent about it and he is sharing this with me. I think,
Okay.
isn't it a better idea?
Yes, madam, I will surely try. I will
Okay.
try that. Yeah.
So can we fix up appointment tomorrow evening when both of you will come here?
Yes, I will come with her after the office.
Uh,
Yeah. Yeah.
And you are going to tell her and I will be there with you.
Sure, madam. I will attend that. Yeah. Thank you.
Please stop here. Now here, the client would have tried to manipulate me by saying, no, I will tell her at home. But I wanted this to happen, and that's why I had to be assertive in telling the client why this was necessary. The client accepted this because I explained to him the logic behind it. I explained to him how their trust with each other is important from that point of view. So many a times they have to be assertive and not get manipulated by the client. The client many a times will try to manipulate you. But you have to be on what you feel is right. So your conviction in your theory is extremely important. Then only you can be assertive with that. Similarly, sometimes in the session, we have also used humor. So let's find out a case in which how uh, humor was used in this case. Now, this is about a girl who is 20 years old but overweight, and she wanted to reduce. She was taking her sessions with a dietitian and gym trainer and everything, but she wanted to be even psychologically prepared to continue her thinking about it. Now she has come in this session when she is feeling very bad about something which has happened. Let's hear from her what she has to say. Yes, Dita, what happened?
Yeah, ma'am, I was following Rujuta Divekar's diet plan, and I'm so happy to share it with you, ma'am. In last 3 months, I have reduced 5.5 kgs of weight. Can you imagine that I could do that?
Yeah.
Yeah, but
And
ma'am,
I
another
congratulated you on that last
yeah,
week.
but ma'am, another bad thing that has happened is last few days, last 1.5 month, I'm just not able to control only, ma'am. I mean, anything that I feel, I just feel like, chalo kha lete hain. Something I see and somewhere I'm not able to control only myself. Last week, what happened, man? My uncle from Calcutta came and he got the rasgulla dabbas, those small, small dabbas that we get of 10 rasgulla each. So I was tempted, and in 2 weeks' time, I have finished practically two rasgulla dabbas. And anytime that I eat one, immediately एक से मेरा क्या होता है, that concept is there, that psychology is there. So ma'am, I'm just eating 2, 3, 4, and I just can't
What did you
control
do?
those things.
What did you do?
So then I ate, madam. So at the time when I eat 3, 4, at that time I tell myself that I will not have my dinner. But when it becomes 8:30, I get hungry and I think, क्या होता है? एक बारी तो uncle आते हैं, so let's have. So and then I eat that dinner also. So all that I had done in the 3 months, that 5.5 kgs reduction, it has again gone back to increase of 3.5
Where
kilos
was
of
that
weight
box
again.
kept?
Sorry, ma'am.
You ate and that box was kept where in the fridge?
No, it was on the box was kept in the fridge, but it was on the kitchen platform also.
Yeah.
So my mother had kept it out to eat for herself, but then I only had it, ma'am.
So you feel you went and automatically had that. You didn't even notice that you had eaten it. Really? This has happened?
No, but
Because
I mean, I don't know what happens, but it just happens, ma'am.
when you're describing, it came in front of my eyes that you went near the fridge. You were going to the other room. You had no intention of opening the fridge also. But fridge automatically got opened. And the two pieces from the dabba, they came like this. And they came to your mouth. So there was no other way you could do except gobbling it.
No, ma'am. No, ma'am. I am only feeling
They,
so awkward.
they automatically came to you and you just helped them. As you finished two pieces, other two pieces also came from the fridge and dropped in your mouth.
No, it didn't happen that way. I went to the kitchen because the rasgullas were kept inside.
Yeah.
I made efforts to open that tin because, ma'am, it is so tightly packed.
So tell me when you went near the fridge. I know you had intention of not eating.
No.
But what went wrong there? What were the thoughts at that time?
The thought was the rasgullas are at home in the fridge and I'm not having it. How can it happen? Something at some sweet which is so favorite of mine and I don't get to it. How can it happen? That was the only thought, ma'am, when I went near the fridge.
And I'm sure you were thinking about this is injustice.
Yeah, this is injustice. Everybody would eat and not me. How can that happen?
Everybody in the house is going to have it, and I can't have it.
I can't have it, yeah.
Okay, that thought came to your mind. Because let's see, was it really injustice? This was something which was of your choice. You came to me on your own to decide to get the psychological support for sticking to your diet plan.
Yeah, not
So that
able
was
to
my
do that.
choice. Injustice is something which is thrust upon you. It was not something thrust upon you. That was your choice. Second thing is, you had made a plan and you had decided, I'm going to follow it through for so many months. So the plan was not made by me or anybody else. It was done by you.
Yeah, I had only made it.
So when you don't stick to that, you knew the consequences also. But that time, what took over was your rebelliousness. Why should I stop myself? So now you have to understand how it is going to help you. Which other thoughts would have helped you to come away from the freeze not picking up?
Probably my own integration towards my goal, that I am the one who has decided about it. So I must follow that.
And I've taken that choice of eating.
Yeah.
Nobody trusted me.
Hmm.
Second thing is when we decided to talk about it, plan also, we have decided something which you love, which you like to eat. You can have it in moderation once a week only. Isn't it? So you have decided Saturday afternoon was the time when something which you like, you will bring home and only have one piece or half a piece.
Yeah.
That is something which that's why it's not injustice. We have made some justice in that you will have that much and once a week. Isn't it?
Right, ma'am.
So now, will you do one thing? I can understand it's very painful. It is in the fridge, but you can't have it.
And everybody else is having in front of me,
Right
so
on
it
a
is
piece of paper.
difficult.
No gain without pain. Okay?
Yeah,
And
ma'am.
you can keep that paper on the this, fridge magnet. Under the fridge magnet.
Yeah.
You can keep this paper. No
No,
gain without pain.
without pain.
You know that because you are you are following it properly,
Yeah.
and because of this, because of that, because stopping yourself, how it has helped you all this time.
Yes.
Okay.
I will try, ma'am. I will
Yeah.
try it the next to the rasgulla only.
Yeah.
Thank you, ma'am. Thank you.
Thank you. Bye. See now in this station also, I never asked her anything about what made her do that. But I used humor here by showing her the absurdity in her thinking. The humor was not used to make the session lighter or add some humor vein in the session, not because of that. But humor had a definite purpose. So I exaggerated what she narrated, and that exaggeration showed her the absurdity in her thinking. So anything we use in the session has to have a specific purpose, specific message you want to drive to the person. And that message will remain in her mind when she goes back. So if it is told in the dramatic manner, if it is told in the manner by which she will be able to imbibe it and take it home, it helps the person. Similarly, I gave her a slogan of no gain without pain. So if you want to lose your weight over a period of 6 months, what you need to do, what pain you have to undergo. But this is all because I'm going to show her what is her goal in that and how our thoughts should be goal directed. As I mentioned, many a times client goes on talking about it. Many a times the patients who linger on A, like talking about the events in their life, painful events in their life. They many a times want validation for their responses. Yes, my husband said like this to me, and that's why I was very angry with him, and I shouted at him. Don't you think that if I'm so angry because of his word, I should behave like this? So she wants validation for her actions and emotions. And it's important for a therapist not to validate at that time, but to ask her, I can understand you were upset with your husband, but what were the choices in front of you? And what are the consequences of each of those choices? So here we are not directing the patient by telling don't do this and do that, but showing the client you had a choice. There were many choices in front of me to respond in that situation. You chose a response which was emotionally debilitating for you. But there were other choices also which you could have taken by which you would not have been this upset. So that's how we call it directive and educative therapy. Summarizing at this point is also very important at the end of the session. Now let's see why people keep on blabbering. Many times people have that poor communication style also. They narrate the events also aage piche, they don't themselves understand what is in the flow and how it should be narrated to the therapist. So many a times we have to become a guide to them for that. When a client gives them blabbering, we can summarize what he has said. What you told me looks like this happened on Tuesday, this happened on Wednesday, and this happened on Thursday. And your response on Friday was like this. So therapist also stands as a guide to the client how to narrate his problems also. Sometimes they are emotionally so upset that it affects their communication also. Or sometimes the client can be very defensive and doubtful whether what I say will be accepted by the therapist or not. And that's why he goes on talking about something which may not be related to his problem. So most important part of A, B, C, D, E, F is it. E is the effective action plan. So like I discussed with Geeta just now, what is the effective action plan? That she will put that slogan on the fridge magnet. She will decide at the end of every Saturday afternoon, she will have whatever she wants. So that is the effective action plan. And what is the feedback? That when she followed that, what has happened? So A, B, C, D, E, F is not circular, not linear, but it is circular because the feedback that the person gets acts as an activating event next time. But after that, the B should be changed to B so that the person will handle it in a more effective manner. So actually disputation is something which we cannot separate from the actual therapy session as it follows along. Even in the first session, you can start disputing the person's idea about their disturbances. A girl complains about her mother-in-law, how she's behaving, how she's nasty and all that. There, right from the first session, I can talk to her in that manner. Yes, she behaved like this. And what were your thoughts about it? How did you respond to that? Now you are feeling bad about that response. How that response could have been different if your thoughts were different. Or a boy who is trying to avoid to appear for the exam. There also we can start disputation right from the first time. What was he afraid about? And what does that failure mean to him? So what we want to dispute is also very important. We don't want to only dispute the irrational ideas in the person's mind, but also explore the weak rational ideas. Person doesn't think like that all the time. He has many a times ideas about which I wish I had not said like this. I wish I should have behaved like this. But that idea is very lukewarm. And we have to heat that emotion by trying to strengthen it as much as possible. Let's take another one example only, which I'm not going to take more time for that. This is the last example. Now, this is a person who has come to me who is very depressed. She has been taking antidepressant for a long time. Her children are away. She stays with her husband. She is around 60, 62. Husband is also retired, staying at home. But husband has been supportive. And she feels very guilty and bad because she can't do the things which she was not doing earlier. So according to her, things which she was enjoying earlier, she makes something at home. काहीतरी चिवडा करायचा, लाडू करायचा, खायला करून ठेवायचं. But now she doesn't feel like, she doesn't even get up in the morning to make a cup of tea for her husband. And she is feeling very bad about it. So I'm going to take only a few snippets of this conversation. Yes, Gita, you said your husband, he goes for a walk in the morning, isn't it?
Yeah, he goes in the. I don't get up, madam. He only goes. He only gets up, make the tea, and then he goes for a walk. I don't get up only.
But when you don't get up, doesn't mean that you are asleep, you know.
So I'm
You
just lying on
notice,
the bed.
notice
I
his
don't.
movements, you notice that he's making,
Uh,
you can hear the sounds from the kitchen that
yes,
he's making
yes.
a cup of tea. And he has told you can leaving and he goes.
Yeah, he tells me from the door. Yeah.
During that time, what is your thought?
I don't feel like doing anything. Neither I am interested for joining walk with him, ma'am. But alongside all this, I just miss of making tea and having it together with him. That is what I miss.
So is there some moment which you feel that you are missing there that time? Which was the moment which used to make you very happy?
Yeah, at that time, madam, having the tea together is the moment that I definitely
So both
miss.
of you sitting at the table
Yeah.
and having tea together. That was
And one
according to you was the
one
family.
particular action used to happen when we used to sit together for the tea. He used to keep hands on my shoulder, just press them for a day, and then we used to have tea together.
Now you don't want to get out of the bed because you feel that making a cup of tea is also too strenuous for you.
Yeah, it doesn't interest me anymore, ma'am.
Okay. Let's find out if husband is making tea for him and you both of you sit and have it together. Can that happen? You don't have to make tea. Let's start only with this. He
That
tells you that tea is, he tells you in the morning that tea is ready. You get up from your bed and go and sit at the table. And you
that
have
may
tea together.
yeah, that may be possible if he makes the tea.
Your husband is sitting by you.
Yeah.
I will ask him. Kaka will say, okay, I will be happy to make a cup of tea for you. So if he has made tea, will that make you at least a little better sitting at the dining table and having tea together?
Yeah, sitting with him definitely will make me feel better, ma'am. I can make that attempt.
See, we want to make these small time slots in the day which
Yeah.
will make you happy. So let's start with this one time slot that he has made tea, he has called you. You get up from the bed, you sit there and have a cup of tea together. Not making tea, not making it.
Yeah, for a very, very long time, ma'am, last 3, 4 years, I have just left this habit. So I will make a attempt if I can do it.
Making tea we will keep at the last.
Yeah.
But at least sitting there and make.
Yeah, you said that he
having
will make
together
it
will
and I
make
have
you
to
happy.
have it with him. I can make that attempt, ma'am.
You imagine that situation closing your eyes, how you will feel. You're sitting there, he's sitting in front of you, and you are having tea together. Even that thought is making you a little better, isn't it?
That gets me to my old memory lane, ma'am,
Okay.
when
Okay.
we were having
So
good
let's
time.
start only with that. Let's start.
Yeah.
Okay. We'll stop here because I don't want to give the homework which is going to be too taxing to the client. And that's why homework, whichever you give, it may be behavioral, it may be cognitive, it may be emotional. It has to be in consultation with the client so that the client should not feel it taxing. At the same time, you show the client that even imagining that homework is making the client feel little better. So which are the different distress causing evaluating cognition? Which are the thinking patterns which make the person emotionally upset? The first is demanding this. It should happen this way. Otherwise, I can't stand it. My son should talk to me nicely. Otherwise, I can't stand it. My husband should listen to at least this much. Otherwise, it means he doesn't love me at all. So these are the demanding statements, demanding cognitions, which create the emotional disturbance and obviously the behavioral consequences because of that. Similarly, awfulizing and terribilizing is something which has not happened at all. But still you keep on imagining how awful it would be. For example, doctor has asked me to get my investigation done. Even that thought makes me very anxious because I start thinking about, oh my God, if it is negative, if there is something in there, if I find out that I have a cancer, if I find like this, and I start thinking about it, awfulizing the situation and making myself anxious all the time. Similarly, low frustration tolerance. People with short fuse have low frustration tolerance. Anything happens against their wish, they can't stand it and they want things to be righted immediately. Next is people rating worthiness and non-worthiness. I made this mistake. That means I am an awful person. I am not worthy of that. In my office, my boss mentioned about the mistake which I made. Then I immediately start rating myself as the worst employer in this company. Similarly, I rate other people because of that. My boss said this to me. How dare he does that? He's such a nasty person. He's useless. So I start rating him also. Now all these cognitions are related to either achievement, comfort, fairness or justice, having control over things, and affiliation. So we have to find out what the person's cognitions are there, which are making him emotionally upset, and how we can try to challenge those during our session by using different methods.
Ma'am has used the time perfectly,
I don't want to
and
overshoot. Yeah.
just 10 minutes are left, and I think it was a very, very thorough understanding. I tried to put a lot of things in chat, but I hope it didn't distract you from the content that ma'am was sharing. Uh, there is a lot of mastery in the way she shared it and the way she gave us, little tips. But the more practice you do, and the more you even try it with each other, as residents, you have that opportunity. You can discuss cases from the psychiatric viewpoint, the differential diagnosis viewpoint, the drug treatment viewpoint, but also the therapeutic viewpoint. And I know all your, like Shilpa is such a great friend for so many years. So many of your teachers are very, very clear on this and they will help you. So if Shilpa and Prajakta want, there can be 10 minutes of Q&A. Please raise anything from the chat box. Also, I've just tried to share a lot of resources there. If we don't get time now, I'm sure the coordinators will share these with you separately. Thank you.
I'll share all these resources which ma'am has sent on the chat on our group. But if anyone has questions, you can put it in the chat or maybe um, unmute yourself and ask.
Because has added already some of the things on the chat. So you can copy that and find it.
It will be nice if you all can put on video. If it's uncomfortable, don't do it. But otherwise, you will get a sense of an more interactive kind of exchange. Feel free to do it if it's possible. There's one question, how to handle avoidant behavior.
Now, avoidant behavior depends upon what is the thinking behind it and what the person is trying to avoid. Are there any positive gains because of that? Or because the person may have avoidant behavior due to avoiding unpleasant situations. And if that is so, we have to first find out from the client what is he trying to run away from. Avoiding is always running away from something. And that running away is probably related to anxiety. So the person wants to situation wants to avoid situations which are creating anxiety. The example which I had noted was the boy who doesn't want to appear for the exam because he doesn't want to face the failure. So in such a case, it's important what is the thinking behind any avoidant behavior? I can't face such situation. So that thinking, that theme, you have to challenge in that person. What does it mean for me? By doing that, because when the person uses avoidant behavior, he feels happy for a while. I could run away from the situation, but he knows in the long run it is not going to handle be useful. So that's the reason it is important to make the person understand that facing the situation is making you upset and okay for a while, but that you carry it in your mind for a long time that I am avoiding that, and that creates more disturbance for you. So at that moment, facing it is more less troublesome as compared to postponing it.
Ma'am, there's another question. Dr. Anisha asks,
Yeah.
what technique to use if there is past trauma?
Past trauma. Yeah. I mean, past trauma, as we say, that trauma is not making the person upset, but the memories of that trauma. And because the person keeps on repeating those memories in the mind, that trauma is something which has happened long back. But why it is there in the person's mind all the time? Many people have traumas, but each and every person doesn't get affected today by that trauma. But because we keep on repeating in our mind those negative memories, so you yourself are adding fuel to the fire by keeping them alive in your mind. So it's important that in that trauma, what are the emotionally disturbing situations? And many a times the person talks about it, and the therapist tries to challenge the inferences by that trauma. Then the person, the seriousness of the trauma or the disturbance created by that trauma can slowly become less over a period of time. Many of us have faced trauma, but doesn't mean that we carry it up with us all the time. But it's only because we keep on repeating that in our mind. And because we keep on repeating, we keep it alive. And that's the reason it is important that emotional part of that trauma. It's not that the situation is making the person upset, but the emotions associated with that situation are making upset. So when it is talked about, talked over and found out that the inferences are faulty.
Any more questions?
Anuradha has given answers to some of the questions, so we need not repeat them. Yeah.
So I think there are no more questions. So we thank you, ma'am. It was like a revision session, and I was all ears. I could just continue to listen to you, but we have a time limit, and we also have a quiz coming. So we thank you once again, Tatte madam, for giving your time and so much of your heart into it. And even Mrs. Geeta, I think Geeta, right? Who
Yes.
also who acted so well, and those sessions were really useful. There was so much. They were so small and yet so effective sessions, and something to learn from each of them, how to handle a client with different types of problems, which I'm sure residents do face uh, in their clinical setup every time. So thank you both of you, and thank you so much, Dr. Sovni, for sharing this and all those small little informations for our residents. They were so useful. I could not, I did not reply to them because we record this and we will put it across to them. there is a group of all residents, so I'm sure Prajakta will do the needful. So don't worry about that. They all will be, we have treasured them, and we will put them across to them. So thank you so much for sharing also. And thank you, Tatte madam. Thank you, Prajakta, for moderating it so well. And we have Dr. Prerna, I think, waiting for us with the quiz, with the small quiz, after which we'll end the session.
I thank IPS Vezot for giving me opportunity to share my thoughts about CBT.
The pleasure is all
Thank you
ours,
for
ma'am.
letting me be there. I enjoyed myself. And I went back to my professor days where I used to have this kind of session. And I'm just kidding, but my students were way more responsive on chat. Okay, over to the quiz.
Because I thought I could just introduce to the topic.
Yes, of course.
So Prerna, Dr. Prerna, she would be conducting the quiz. She is consultant psychiatrist at Early Intervention and Rehab Center at Nair Hospital. Over to you, Prerna.
Thank you, Prajakta. Very good evening to respected seniors, Shubha ma'am, Anuradha ma'am, and Shilpa ma'am, and hello all residents and friends. I think after that very interesting and insightful role play, it indeed was a very nice session because I thoroughly enjoyed it, and I think something like this is very important for residents as well because we struggle in implementing what we read in textbooks. So live demonstration was, I think, useful for all of us, and it will be helpful for us in our individual practice as well as our day-to-day lives. So having such a insightful lecture, let's just go on to some few questions on CBT and let's see what we have all understood. So I'd request Yogendraji to kindly start the Zoom poll for the quiz. Thank you, Yogendraji. Is the screen visible to all the participants?
Yes, it is.
All right. So we begin with the first question. The model of cognitive behavior therapy was given by Aaron Beck, Albert Ellis, Judith Beck, or Mission Baum.
1 minute. Someone says screen not visible. Swara.
No, we can see. We can see. Yeah.
Swara. Can you see the screen now?
Yogendraji, can you restart the quiz? Sometimes it gets hanged. Yeah. I hope it's visible now to everyone.
Is it visible to everyone? Can we start it?
Anyone who can't see the screen? I think let's start.
Yeah.
All right. So the first question, the model of cognitive behavior therapy was given by Aaron Beck, Albert Ellis, Judith Beck, or Mission Baum. We move to the next question. The concept of rational and irrational thoughts was given by Nancy Beck, Albert Ellis, Aaron Beck, or Bandura.
The options are not seen on the screen, Prerna.
No, they're not visible.
No.
Yogendraji, can you
Options
look
of the
into
first two are visible, of the second are not visible.
So you have to move
now,
it.
now is it visible?
Oh, after you respond. Okay, okay, then it's fine. Yeah.
You can scroll by. Let's move to the next question. The assumptions which influence information processing and organize understanding about ourselves and the future, and which often remain dormant till a stressor arises, are termed as automatic thoughts, core beliefs, cognitive distortions, or intermediate beliefs. I'll repeat the question. The assumptions which influence information processing and organizing understanding about ourselves, others, and the future, and which remain dormant often till a stressor arises. These are termed as automatic thoughts, core beliefs, cognitive distortions, or intermediate beliefs. The next question: rules, attitudes, and assumptions are categorized under schemas, core beliefs, intermediate beliefs, or automatic thoughts. The next question is: thoughts that pop up into one's mind when a person is stressed or upset are termed as irrational thoughts, delusions, automatic thoughts, or core beliefs. If you all have missed a question or want to move ahead, you all can scroll up and down on the poll. The next question is: which of these is not a cognitive distortion? Arbitrary inference, rationalization, personalization, or all or none thinking? Moving on to the seventh question. Which of these techniques is not classically used in CBT as a part of problem solving? Cognitive rehearsal, Socratic questioning, validity testing, or developing emotional insight? Moving on further, which of the following is a process of holding extreme beliefs on the basis of a single incident and applying them inappropriately? Selective abstraction, catastrophization, overgeneralization, or personalization? The next question is: this is an example of a cognitive distortion which you have to identify. A student before an exam thinks, if I don't get full marks, I am a failure. So is this all or none thinking, personalization, magnification, or minimization? The last question is: the coping gap model is a model of cognitive behavior therapy which is used for children with depression, children with anxiety, children with psychosis, or children with ADHD. So far only 16 out of 33 participants have answered the question. We'll give a minute or two for everyone to answer. You can scroll and answer the questions if you have missed any. So I think most of them have answered. I think we can end the quiz. Yogendraji, if you can end the quiz, please. All right. Thank you everyone for participating in the quiz. So should I share the answers as well?
Yeah, please.
Yes. Okay. So the first question was the model of CBT, and that is given by Aaron Beck. And the concept of the next question is the concept of rational and irrational thoughts, which was given by Albert Ellis. The third question was about assumptions which we form about ourselves and which remain dormant till a stressor arises. So that is a core belief. Rules, attitudes, and assumptions, these are categorized as intermediate beliefs. Thoughts that pop up in one's mind when a person is stressed or upset, they are called as automatic thoughts. The sixth question was about cognitive distortion. So rationalization is not a cognitive distortion. Which of these techniques is not used in CBT classically as a problem solving technique? And the correct answer is developing emotional insight, which is a classical principle of REBT. The eighth question is which of the following process of holding extreme beliefs on the basis of a single event and then applying them inappropriately to other situations as well? So this cognitive distortion is termed as overgeneralization. The next one was about a cognitive distortion which a student was having before the exam, stating that if he or she does not pass, then or doesn't get full marks rather, then he or she is a failure. So this is termed as all or none thinking. And the last question was coping cat model. So that is used, it's a CBT technique which is used for children with anxiety. So over to you, Prajakta, and thank you for the opportunity of conducting the quiz.
Thank you, Prerna.
Thank you, ma'am.
Wonderful quiz.
Thank you.
Thank you so much, Prerna. It was questions are really interesting. Okay, so before we end, I've shared the feedback link, and we would really request everyone to fill the feedback because that really matters to us to kind of improve on our next sessions. Shilpa ma'am, if you would like to say something at the end.
No, just thank you to you and Prerna, and I think Satya madam and Dr. Anuradha have already left, but we thanked them before. I think a wonderful session, and I wish that maximum, like one point I saw there were 82 participants or 84 participants. So I hope that most of them have learned and taken inspiration from and also apply this in day-to-day life, clinical or personal. So with that, I think we should end today's session. Thank you, everyone. I just hope that, I mean, I don't know what to do about this, but 84 becomes 33 when we start the quiz. So I don't know whether we should take a pre-session quiz. I'm just thinking aloud. I don't think that's possible, but there should be some strategy for this. Thank you.
Ma'am, if I can suggest something for the quiz, if we can take it before we address the audience queries, like after the end of the session, because most of them wait to hear the responses and to hear the answers. So maybe
we could do that. Because already towards the end, people are already leaving. And then by the time we arrive, which the quiz is made for them, and
They all
they
drop
are
out.
only not there. So out of like organizers, there are 6 or 7 people out of 33. So we are only there who are answering the quiz, and there are only 25 people. So maybe we should change the timing or something. Nice quiz though.